Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on mentors and motivators who are consistently reshaping, redefining, and rediscovering the field of medical healthcare. I would like to welcome Dr. Lyn Patrick, a renowned naturopathic physician with over 3 decades of clinical experience. As a member, planner, and faculty member of the American College for Advancement of Medicine, Dr. Patrick is committed to the practice of preventative care. Good morning, Dr. Patrick. Thank you so much for being with us today.
You're welcome, Monica. I'm happy to be here.
Well, before we get on to what you'll be talking about in the conference and what your true passion is in the field of medicine, let's go back to the beginning of your medical journey. If you would just enlighten us a bit as to how you originally got into medicine.
Sure. It's a great story, actually. So I was an undergrad doing pre-med with a gentleman named Jeffrey Bland, who many of you have heard of. He was actually teaching a program in nutritional biochemistry at State College in Washington that the students actually designed and asked him to speak. It's kind of a unique situation. So I was very, very fortunate and privileged to have the brain of Jeffrey Bland as a little 20-year-old sponge, you know, soaking up his wisdom and his incredible insight. And this was back in 1978, I believe. So there was no functional medicine, there was no integrative medicine, there was only standard medicine and, you know,
Eastern medicine.
Eastern medicine for sure, and, you know, maybe some herbalists, but naturopathic medicine really had not gained a foothold yet in the awareness of the public or in the awareness of the medical community. So in my exit interview, you know, from the program, Dr. Bland sat me down. He said, "I really think you should go to medical school." Now, at the time, my boyfriend was at UW Medical School, and so I would go up to Seattle to visit him, and he was not a happy camper. I would sit in on some of the classes, and I would think, I just can't figure out how this is going to be relevant. So that was my experience at medical school, and I said, "Dr. Bland, I cannot imagine myself doing that." And he said, "Well, I'm not talking about any regular medical school. I think you should go listen to a gentleman named Joseph Pizzorno, who's a naturopathic physician who's starting a new school called at that point, it was the John Bastyr College of Naturopathic Medicine." So he was actually coming to the campus. I went to visit him. This guy was a scholar at Harvey Mudd College. He was brilliant. He had a very high IQ, and he could speak eloquently about the role of nutrition in human biochemistry, and that was my thing. I was getting a degree in biochemistry, so my eyes just kind of popped out of their sockets, and I thought, I want to do this. I really want to do this. But I still had those reservations because of my experience, you know, at least secondhand, with standard medical education. So I had a summer job working with underprivileged kids at a camp. They were not healthy children. They were working in a very kind of sequestered environment out in the woods, and I became the nurse because there was no nurse, so I would take them to the doctor.
And you were 21, 22?
21, yeah.
Okay.
And even at that young age, when the physician that was seeing them prescribed steroids for their acute strep throat, I knew something was very wrong, but I didn't have the authority or the education to do anything about it. So one day I was sitting at the lake, you know, very frustrated and angry and despondent, and knowing that, you know, for whatever reason, the care of these kids was in my hands. And I know it sounds woo-woo, but I literally heard a voice outside of my own head that said, you know, you can do this, go back and apply, and you'll be okay. And so I did. And that was 1978, so here I am. Some years later, having practiced naturopathic medicine and been involved in several different projects along the way, very, very glad that I heard that voice and listened to that voice.
I'm sure that voice, whether or not you've since heard it again or not, has carried you in your medical career all these years.
Well, you know, it's funny because I haven't thought about this for, I don't know, many, many, many years, but you brought it up, and I thought, It really happened. And I think that it was a guiding force in my life that's kind of helped carry me through to where I am today, for sure.
So from my research, I understand that you started out in your career working with AIDS patients and HIV.
I did. In my residency, back when I was even a student still, that was the beginning of the AIDS crisis. And so nobody knew what to do. It was a very scary time. It was a very confusing time. There was a lot of overwhelming infections that men and women had, and we had to do whatever we could, whether it was allopathic, standard medicine, or botanical medicine. I worked with the infectious disease doc. We worked with some of the primary care clinicians that just had to take on this enormous task of treating what seemed to be, it was originally called gay cancer, but it wasn't. It was just an overwhelming virus. And so we had to learn really, boots on the ground, how to take care of this really very tricky infection that led to many other opportunistic infections. So it was my time in the trenches, for sure. And that led me to get very involved in hepatitis C infection, because at one point, this was probably in the mid to late 90s, all my AIDS patients would come in and say, I've been diagnosed with hepatitis. And I thought, well, that's acute hepatitis. You need to get treated right away. They'd say, no, it's chronic. I'm going to have it for the rest of my life. And nobody knew. There was no treatment for Hep C back then. I was so passionate about learning about Hep C that I ended up going to a National Institutes for Health conference where the NIH brought world experts from all over the world to talk not only about Hep C, but to talk about what they called alternative medicine for Hep C. It was a fascinating experience. They brought in a team from China, from Korea, from, I think there was a team from Russia. There was an anthropologist from the Amazon who had actually found a plant in the Amazon that cured hepatitis D, delta, which is a form of hepatitis that's you die from, basically. So at that meeting, I ran into a woman who I struck up a conversation with, and it turns out that she was working for an organization that was planning to do a national brainstorming team, think tank project for Hep C. And the originator of that project was a well-funded gentleman who had Hep C. He had no idea how he got it, and to this day, nobody knows how he got it. He was kind of your average basketball guy, right, who played basketball in college and had a, very clean lifestyle. His mom was a Buddhist hippie, so he had never taken drugs in his life. So he was a little afraid of them. So that launched about a 10-year project with some of the top research hepatologists in the United States that I've become very good friends with, to actually put together a clinical trial using, at that point, we were looking at Chinese medicine on top of standard antiviral treatment to see how well it would work in hepatitis C. That was a long time ago. Now, Hep C is virtually curable with some of the new antivirals that we have. It's a miracle, just like the antiretrovirals that came out for HIV and AIDS. So we're on the other side of it. It was a courageous project with, involving millions of researchers all over the world. And I think that we learned a lot from that experience. One of the battles we're now looking at is that a lot of people with HIV and AIDS are getting fatty liver from their treatments. And so now we have another challenge that we have to deal with. There are some side effects from the chronic Hep C medications as well, but much fewer.
So you lecture internationally on your research, correct? Regarding
do.
This topic. Okay.
I do. I think now that Hep C has become curable and the antiretrovirals for HIV are available, that's a battle that we've won. That battle is over, thank God.
Can you share some of the strategies and practices and protocols that you've utilized to help in the treatment of chronic hepatitis C and liver disease and endocrine disruption?
Sure. So one of the things that we know as liver disease advances is that there's liver damage. We call it cirrhosis. So that's at the point, the liver is an amazing organ because of its capacity to regenerate. We can survive with 1/3 of our organ intact and literally kind of grow a new liver. But if we cannot stop that process, it doesn't matter. So what we've really started to look into is what is cirrhosis? How can we turn it around? And as you know, there's an epidemic. It's a very frightening epidemic of non-alcoholic fatty liver disease in this country. We know fully that about 25% of American adults have non-alcoholic fatty liver disease. Very few of them know it.
Now, is this what drove you to focus on the environment and the toxic, should I say, our toxic environment?
Yeah, you know, it was a parallel path. I did undergraduate training in environmental medicine in 2001 because I lived in Tucson, Arizona, which has its own very interesting history. The whole southern part of the city has been contaminated with a solvent called TCE, which is in the water supply. So there's a fairly high rate of cancer in the southern part of the city. And I knew that a lot of my patients, I couldn't get them well. I just couldn't because I didn't really understand what their toxic burden was. So at the same time that I was involved in learning basically I call it my hepatology, my 10-year hepatology residency, I was also being trained in environmental medicine. And at some point, those two knowledge bases converged and I realized this is not just diabetes, it's not just obesity, there's a whole nother track. And fortunately there's a hepatologist at the University of Louisville, brilliant man named Matthew Cave, who's also on this track, and he's published several articles looking at toxicant exposure and fatty liver. So we know that there are specific things that you and I are exposed to just in daily living that are toxic to the liver and can cause elevated liver enzymes, not to the point of hepatitis, but you know, low-level elevation that we carry a body burden of. So not only are we exposed to them every day, like BPA and phthalates, but we inherit them either in utero or from our diet, and we carry them along. So these persistent organic pollutants, they're called, can be in our bodies for 30, 40, 50, 60, 70, 80, 90 years. And my research and my teaching is focused on how do we look at those pollutants? Because it's one thing for me to say to you, you know, Monica, I think it might be helpful for you if you're interested in, I know you're not interested in having kids, but if you were, let's just pretend, you're probably done, but if you were interested in having kids, it might be really helpful for you to avoid makeup or personal care products that...
Trust me, I'm not avoiding makeup.
Yeah, but that contain phthalates and BPA because those have an effect on your endocrine system and your ability to reproduce. That's an easy solution because those chemicals come in and out of our bodies.
So it's easy
daily.
to lower the toxicity of that in your body. Okay. If you
However, chemicals called PCBs, which stand for a long word, polychlorinated biphenyls, that we get from eating, unfortunately, butter and farm salmon and meat, those persistent pollutants can stay in our bodies for decades and have a direct effect on liver function. And that's what Matt Cave has kind of shown. As well, the metals, lead and mercury, which we're all exposed to, you know, I'm a little older than you, I carry that body burden because of the air that I breathed when I was young. You know, today, you and I probably have a blood lead level of 1 or 2, right? That's kind of what we've breathed in, inherited in utero. In 1976, the average blood lead level for kids was 88. I show that slide and the doctors are like, that's not possible. And I say, well, you were born after 1980, you know, and so you don't know this. But so those of us who were born before 1980, we carry that body burden of lead.
My mother grew up on a farm, so the chances are that potentially mine was even higher, correct?
Yeah, so, well, because, the reason is because leaded gasoline is still allowed. I don't know if you know this, but leaded gasoline is still allowed for small engine airplanes and for farm equipment. So I think that our job as clinicians now is to really start recognizing what is body burden, what does it consist of, and how can we really assist our patients in lowering that body burden? Because we are finding out now that lower and lower levels of lead are connected with not only dying from a heart attack, but dying from a stroke. That paper just came out this year. Bruce Lanphear's amazing paper in Lancet Public Health, looking at the relationship between the body burden, which, you know, blood lead, so to speak, is roughly equivalent to body burden, and the risk for dying of a stroke and a heart attack. And it is well below what we consider the safe level of lead of 5.0 microgram per deciliter. So if you went into your doctor and you said, I grew up on a farm and I want to have my lead checked, and he or she would say, okay, fine, simple test. The laboratory for you as an adult female would say 10 or below is safe. But this new research that comes out is very clearly points out that we know no level of lead is safe, and probably well above 3.0 microgram per deciliter, there's a serious increased risk for heart disease, but even as low as 1 now we're finding out.
So as far as testing and lab work, et cetera, when a patient comes to a practitioner's office, for those in the integrative and functional medicine space, how would they interpret the labs differently?
This is why we have to teach this stuff, because the reference ranges for laboratories are based on their reference population, which is simply a population of people that they test for lead. It's not based on the epidemiological literature or the paper that just came out this year in Lancet. So that's why we have to teach specific, it's toxicology, but it's toxicology for the enlightened integrative care provider, really.
So what are some of the red flags that a patient would be presenting with to identify that they are potentially have been exposed to some toxic?
So let's take 2 specific and very different areas. So area number 1 would be, have you been exposed to enough chemicals and your immune system is sensitive enough that the intersection of your immune system and those chemicals causes problems? So for example, the questions we always ask our patients are, do you have any problem walking down the detergent aisle of the grocery store? And you would be surprised.
What would be the reaction, like from the patient that we would walk down?
Respiratory, cardiac, just feeling unwell. So that exposure, and there is exposure to the fragrances, for example, or the chemicals in that become airborne, either pesticide, you know, the pesticide aisle at your local hardware store or the detergent aisle, they trigger an actual immune reaction. One of those manifestations of that immune reaction is called cachosmia. You can use that word at your next cocktail party. Impress your friends.
How do I spell it?
C-O-C-O-S-M-I-A. So cachosmia is an actual upregulation of the immune system that makes you smell things that other people can't. So you probably will notice, if you pay attention, that you have some friends who are like, what's that smell? When they walk into a room where there's been somebody either smoking in the room previously or who's had perfume on. Those people will also have other symptoms. So cachosmia is actually an indication of an immunological sensitivity to a chemical related to continued exposure and an immune reaction. So that's one thing, sensitivity to exposure. These folks probably cannot take standard doses of prescription medications or OTC medications, and that's another question we ask. You know, do you have a problem taking standard doses of either prescription drugs or drugs that you get over the counter? Because their livers have a altered ability to break down and excrete these drugs based on a whole bunch of parameters related to their toxic exposure.
So what would the presentation be that they would even know that they have an inability to metabolize those drugs?
So they would take, let's say, a standard dose of an antihistamine, and it's like taking 10 times that, so they'd fall asleep.
Okay.
So they would learn over time, you know, and my experience with these people is they absolutely know from having those unfortunate experiences that they cannot handle a standard dosage of a prescription drug. And the last question we ask them is, can you drink caffeine after noon or at all without experiencing an upregulation of your nervous system? So we say insomnia, nervousness, sweating. And so the ability to break down caffeine, which is also interestingly a reflection of liver function and an alteration of liver function, is a problem in some of these chemically sensitive people. So I'll give you an example. So I had a patient, I had an environmental medicine practice. Soon as I got out of postgraduate training for environmental medicine, I was depressed and enlightened at the same time. And so I changed my family practice over to environmental medicine. So we had a gal who would lose consciousness. She'd actually faint spontaneously whenever she was exposed to fragrances. Now I know that sounds crazy, or that she might have a psychological problem, but she didn't. Her immune system was upregulated to the point which that exposure would cause not just an immunological reaction, but kind of a vasovagal reaction. She would faint. So we had to have a fragrance-free policy in our office for many reasons, but you know, that was one of the kind of, you know, that sealed the deal. Like, we really can't have her fainting in our waiting room. We really have to have a fragrance-free policy. There's a researcher, her name is Steinman, and she was actually, fascinating story. She was an atmospheric scientist who was at the University of Washington, who started researching fragrance sensitivity. And she has polled, through a scientific process, polled thousands of people, both in this country and in Sweden, and she's found that 33% of the representative population of adults that they have surveyed have reactions to fragrances. Everything from migraine headaches to respiratory problems, asthma, allergies, and this is documented. But she's documented that it's a huge problem and that people actually avoid dryer sheets because of these sensitivities. And actually, as you probably know this, that perfumers add a chemical called phthalate, which is a plasticizer, to fragrances because that plastic carries the fragrance into the environment and makes you smell really nice even if someone's standing 6, 8, 10, or 12 feet away from you. Now we know that phthalates have a variety of effects on the endocrine system. So this was discovered when one of the researchers looked at young boys and found out that phthalates from the plastic in the NICU, you know, the neonatal intensive care unit, actually altered the reproductive development of these boys, and also in utero. They were exposed in utero from their moms. So that was kind of the beginning of taking phthalates out of neonatal care, for sure. But we also know that these chemicals have an effect on the neurologic and the immune system. And that's why people can have these crazy reactions, you know, that we can't explain other than through those mechanisms.
I've read that there is an enormous epidemic now of neuroinflammation caused by toxic exposure.
Right.
So can you elaborate?
Sure. I'm sure everyone watching has heard of a neurologist named Dale Bredesen. Dr. Bredesen is probably revolutionizing neurology, but specifically the care and treatment of dementia, Alzheimer's, and that's kind of his area of expertise, and some Parkinson's disease, looking at PET scans and looking at what's actually happening in the brain, but also looking at the causes. And so there are a number of different categories that can occur simultaneously, called the perfect storm, right? And one of those categories is metal exposure and pesticide exposure. And so we know, for example, that pesticide applicators, so those who actually work directly with pesticides, those pesticides affect the brain in a very specific way and cause neuroinflammations. Neuroinflammation as well. The metals, mercury and lead, cause neuroinflammation. We know this in utero, as well as from looking at aging patients. And so this model of treating Alzheimer's dementia and adult onset dementia, which is becoming, by the way, a concerning problem. Adult onset dementia starts in your 40s. It's not like Parkinson's or Alzheimer's, which manifests later. It's the same cause, it's neuroinflammation. So how do these toxicants cause neuroinflammation? There is kind of a common pathway, and that's through the generation of free radicals. Pesticides do that. The pesticides we use today and the ones that we carry. So you and I, 99% of everybody else on the planet, has the metabolite of DDT in our bodies. You remember DDT? Mm-hmm. It was out, you know, it was taken out of commerce, but it's so persistent that we still carry it. But the pesticides we use today don't always end up residual in our bodies. They do the damage on their way through. And so it's very important for us to avoid pesticides in our food, in our water, and in our air, and to also make sure that that free radical damage is minimized by taking a healthy cocktail of antioxidants every day. You know, men, women, and children should all be taking antioxidants.
There's so much exposure, though. We talk about BPAs and GMO and glyphosate, and I mean, so how does one person just, how are you able to just minimize and to mitigate the possibility of just being completely exposed?
I'm here to talk about that. Dr. Jill Carnahan, who is a brilliant, amazing clinician, is also very aware of that because of her own history, and also she's been trained in environmental medicine. So we have a plan. There actually is a plan.
Can you share a little bit of that?
Sure. And the plan is, and I would put, and I, you know, ask Jill, but I bet she would do this too, put diet #1. We are now living in an age where I'm sad to tell you this, that eating a conventionally grown, a diet made of conventionally grown produce is, it has some risks.
In the United States?
In the United States, well, in other countries too. Other countries actually, there's some countries, South America, where some of the pesticides we've outlawed are still used. In fact, the USDA, U.S. Department of Agriculture, for the first time in 2015 started reporting that they were seeing much higher residual levels of DDT in our food supply. So DDT is making a comeback, apparently, because of the imported produce. So, because of the residual, so these are the pesticides that are residing on fresh fruits and vegetables and in grains because of our agricultural practices, they have not only carcinogenic effects, but they have neuroinflammatory effects. And we would love to think that organic produce is completely safe and devoid of pesticides, but that's not actually the truth. There are residual pesticides on organic produce as well, but it is the minimal risk that we can take is eating organically. And Dr. Carnahan recommends this, and I recommend it, that we put our patients on 100% organic diets.
So everything that we buy needs to be organic. It's not just, you know, that list that they say, the fruit that must be organic versus the ones that
or the dirty dozen.
The dirty dozen,
right. So the problem with the dirty dozen, and I'm very grateful that that guidance exists, but the problem with the dirty dozen is that it's looking at the vegetables and the fruit that are most likely to have residual pesticides. What it doesn't address, and I'm actually writing a book about this right now called the Dirty 30, the new Dirty 30, because it's really the Dirty 1000, but you know, it's not the dirty dozen anymore. The EPA admits, and from their research, there is a 6,000-fold difference in toxicity between pesticides. Wow. It's a huge spectrum. And what the Environmental Working Group does not address is that range of toxicity. Fortunately, there are researchers who are looking at this. Dr. Cynthia Curl at the University of Idaho has published this research, and thank God for her, looking at the actual metabolites in kids' urine. She does a lot of pediatric research now. She's doing it with pregnant moms. And what those metabolites, what pesticides those metabolites signify. So What's the actual pesticide really in the food? And then she rates that pesticide in terms of its toxicity according to the EPA. And what she's finding is something very, very different than what the Dirty Dozen list says. And some of the most toxic conventionally grown foods, unfortunately, are the ones that we would tend to go for in restaurants, like the brassica family, Brussels sprouts, broccoli, cauliflower. You know, that's what I would eat when I go out to a restaurant, right? So I think that we have to really look at this issue head on. You know, glyphosate, it's used as a desiccant, so particularly for grains. Oats, and probably the most high level contaminant food that's been researched for glyphosate. And we're talking about Quaker oats, you know, healthy for you. I'm talking about this in my presentation this weekend, that the residual amount of glyphosate in oats makes it really inedible as a food, especially for kids. Now, unfortunately, because of some of the governmental regulations, glyphosate has not been studied as much as we really want it to be studied. And I know that Dr. Bush has talked about this in interviews with you, and he's really done the deep dive on this. But from what we understand, glyphosate, there's a patent for glyphosate as a pesticide, right? It's a pesticide. It's also an antibiotic. It's got a patent as an antibiotic. It sterilizes, in a very selective way, the gastrointestinal tract of certain animals. We haven't been able to do this research in humans, but we've done it in animals. Unfortunately, the kind of selectivity it has is for the good guy bacteria, and the kind of the organisms that are resistant are organisms like Salmonella, botulinum, and Clostridium difficile, which causes a very severe form of diarrhea in hospitalized patients now, C. diff, enteritis. So I'm pretty clear, and I think there's a growing number of pediatricians that have written books about this that are also clear that to have healthy kids, we need to feed them 100% organic food. We as adults also need that.
What about the toxicity in antimicrobials, like Purell, for example? And
Purell is a hand sanitizer, right? And it contains an antimicrobial called triclosan. Triclosan is also embedded into fabric. It's called Microban. So it's in our clothing. It's in our toothpaste. Now, just this year, I can't remember the agency that did this, but triclosan is now banned, but only in hand soap. And that ban doesn't even take place until the end of the year. So it's still being produced. There are industries phasing it out. So who cares? Why is triclosan bad? Well, what we know about triclosan is that, at least from the research, it is responsible, or there's a relationship between MRSA and triclosan, methicillin-resistant Staph aureus. Everybody knows MRSA, it's a household word. And that in cultures of skin bacteria with triclosan, these small colony variants, mutants, will go on to actually become MRSA. So that's not good, right? The other thing about Purell, hand sanitizers, and this, I can say this because I have a very good friend, Dr. Anne Marie Fine, who's a global consultant to the cosmetics industry and has written books about this. She's an expert, and she schooled me well that many hand sanitizing emollient, meaning hand softening, skin softening products, have something called dermal absorption enhancement chemicals.
Even our moisturizers, correct?
Okay. That's how they work. And how they work is that they actually break down the barrier on our skin. Now, we don't like to think about this. I don't like to think about this. But we all have a dead skin cell layer on the top of our skin, right? And we like to get rid of it. You know, we use all kinds of things to get rid of that dead skin cell layer.
The exfoliants that we use.
Many, many different types of exfoliants. But the problem is that it's there for a reason. We've evolved as animals, you know, to have this because it's protective. And so what hand sanitizers and any kind of emollient, application, unless you're using something that's organic and just an oil, will help break down that dermal barrier. Now, the issue with this is not so much about MRSA, it's about the absorption of toxicants from the environment. And Dr. Fine has actually sent me some articles looking at the absorption of airborne phthalates through the skin, which are highly enhanced BPA, the poster child of all chemicals for endocrine disruption, for screwing up the endocrine system, both in utero and in fully developed adults, is absorbed much better when you have Purell. And this was actually a study done by Fred Vom Saal, brilliant study where he took a bunch of graduate students, they went into a fast food restaurant, or no, they simulated a fast food restaurant, because fast food restaurants, Purell and thermal receipts, right? And thermal receipts are a very good source of BPA. So they looked at how easily does the BPA get into your body. Once you have that thermal receipt wadded up in your hand for a few minutes. And so they looked at the absorption through the skin. They were actually able to look at absorption through the skin versus if you put a French fry into your hand and you eat that French fry. So what they found out was the dermal absorption through the thermal receipts was significantly higher than actually eating the BPA, which is what we eat when we eat canned spaghetti or canned coconut milk is pretty high in BPA. So this little known fact about these dermal absorption enhancement agents, which all cosmetic chemists know are there because they put them in for a reason, really we have to also look at personal care products for sure because of the fragrances, but also because of these dermal absorption enhancement compounds.
Frightening situation.
But speaking of the plan,
yes.
So the plan is, and this has actually been studied, there are BPA-free dermal absorption enhancement agents, agent-free cosmetics and personal care products, right? And there are organizations like madesafe.org that actually rate them, so you don't even have to do the homework. Wonderful moms out there that give me hope every day, who are doing this incredible work to help vet products. And they know about dermal absorption enhancement agents. They're very, very well schooled. And so they get the companies to disclose these ingredients, and then they list them on MadeSafe. So I have a very soft spot in my heart for mom scientists who are doing this work.
We need to get some of those mom scientists involved in public service.
Yeah. You mean elected?
Correct. Correct.
Yeah.
Exactly.
They're pretty busy. It might have to be you and me.
More so you.
Yeah, no.
Do you have my vote, Dr.
I've already
Patrick?
been asked and I've already declined.
So tomorrow you'll be giving a lecture to
I'm
200 constituents. So
correct.
What would be the most important nugget?
Wow. In addition to what we've already talked about. So I'm going to be speaking in the autoimmunity module. And we know, and this is a fact that not everybody knows, but it is known in science that the incidence of autoimmune disease in this country right now outpaces cardiovascular disease and cancer put together. Amazing, right? We thought cardiovascular disease, it is still the leading killer in the United States, but it's not the most common chronic degenerative disease. And unfortunately, the majority of people with autoimmune disease are women. Unfortunately, what nobody's paying attention to is women have twice the BPA exposure that men do. Why? Because we use cosmetics. We use more personal care products. You know, it's a slam dunk if you really look at the epidemiology of it. But BPA causes autoimmune disease. It's pretty clear, right? So I think my message would be that we as a group of healthcare providers need to speak with a single voice about regulation. The American Academy of Pediatrics, the American Academy of Obstetrics and Gynecology has already done this. You know, they've come out, and the Global Organization of Endocrinologists that is escaping me right now what the acronym is, but they've already come out with 2 white papers on this saying we must take endocrine disruptors out of commerce. And we must. BPA has to be taken out of commerce. It just does. And it's the poster child. It's in everything. So, but I guess my main point is let's educate each other and ourselves and pass it on en masse to the public so that everyone has the resources and the cultural norm is to avoid these chemicals. You know, we can create that. The moms of sick kids are already doing that. You know, they're creating that culture.
So is there anything that we can do to resist with you know, in addition to watching what we're exposed to and what we're putting in our mouths and our environment that we're living in and exposing our children to? Is there anything that we can do? Is there a supplement? Is there something
Sure.
that we can do that would help resist how our bodies are metabolizing our exposure?
That's a 2-hour answer. I'll try and...
How about a 2-minute version?
2-minute version of that answer is we have to eliminate high fructose corn syrup from our diets. High fructose corn syrup is a toxicant. I was one of the authors that published the original paper showing it's contaminated with mercury. Every mom should know this. The Corn Sweetener Manufacturers Association doesn't want you to know it, but it's in the medical literature. I worked with an FDA bench researcher who lost her job because she published this article. That it is a process, a manufacturing process that puts mercury into our food supply. So we got to get mercury out of our food supply. We have to get high fructose corn syrup out of our food supply. Myself and hundreds of other folks that are healthcare providers, specifically pediatric endocrinologists, are saying, you know, we must get it out of the food supply. We literally have to make it, we have to regulate it out of our food supply. The second thing is to really take a look at, you know, for clinicians and for patients, you know, all of us to take a look at how our body's regulating insulin. You know, fasting insulin levels, crucial. 2-hour postprandial glucose tolerance insulin levels, crucial to really help everyone, because we're all different. We all have different inputs that cause us insulin resistance, to actually decrease insulin resistance, get insulin levels down, and stop what many researchers are calling adipose toxicity, that the adipose cells actually become toxic. And that's why there's this influx of free fatty acids going into the liver. And so antioxidants. Vitamin E is a very important antioxidant in treating fatty liver disease. It actually is recommended by the American Association for the study of liver disease. You know, they create the policy pretty much in the recommendations for liver disease in this country, and they recommend vitamin E, absolutely. So we have these fat-loving antioxidants. We have to use a lot of them. But then there's that whole process of, you know, why are we full of free radicals? That's an important question. Why is our antioxidant reserve depleted? You know, that's something we have to look at, and that's where we have to go back to toxicant exposure, because all of the organophosphate pesticides increase free radicals in our body. That's one of the millions of reasons why we need to really remove pesticides from our diets and our kids' diets. And the only way we can do that right now is by eating organically.
So, doctor, is it beneficial to detoxify our body, like through chelation therapy or whatnot?
Sure, absolutely. So when we establish that our patients have a body burden, and we do that through laboratory testing. So let's pick an example. Let's say someone who has had a high fish diet, and specifically now we're not just talking about tuna, shark, and swordfish, because half of our lake and river bodies, the fish in them have mercury levels that are above the allowable EPA limit. So we're talking about lake and river fish as well as mercury exposure from vaccines and from amalgam fillings. So that's one of those persistent organic pollutants that stays in the body. Half-life in the kidneys is 30 years, 5 half-lives to get something out of your body. Wow. You're not going to live for 150 years. So we have compounded chelating agents that are very effective in removing the mercury burden from the body very safely. Now, the application of those chelating agents is a little bit tricky in chemically sensitive patients. There's many things you have to do to make sure that that patient is ready to undergo that chelation process. But that's straightforward, right? You take the agent, the metal comes out. What's not so straightforward are the massive amount of the other persistent organic pollutants, like, let's say, PCBs, which I talked about, the persistent organochlorinated pesticides like DDT and DDE, which there's a 99% chance in your fat cells right now. You have a measurable amount, a significant measurable amount of DDE. That's been proven by the Center for Disease Control. That's a little bit trickier, right? And that's where this kind of interesting cultural phenomenon of detox comes in. Unfortunately, going on a 3-day juice fast or a 7-day juice fast isn't going to do anything to rid your body of those toxicants. Because even if they get out of your bile and into your intestinal tract, or from your blood into your kidneys, they can be reabsorbed. And this process called enterohepatic recirculation, or recirculation in the proximal tubule of the kidney, are what we address with clinicians in our teaching. Now, there are ways using natural products, not, simple natural products, not patented, trademarked, specific natural products, but a variety of natural products to stop that process of reabsorption and get those toxicants from the fat tissue into the liver, into the bile, and from the organs into the bloodstream and into the kidneys. And it's a pretty simple process, actually. One that, that certainly benefits from clinician assistance, but one that doesn't involve prescription medication. Like chelation involves prescription medication. It has to be done very carefully, has to be supervised. Taking enterohepatic reabsorption, sorry for that long word, but taking liver reabsorption blockers like fiber and specific green vegetables high in chlorophyll, that doesn't...
Organic, of course.
Of course. That doesn't necessitate a prescription, and that's something that can be applied in general to a patient population. That's probably a lifestyle that we should adopt. If we're really going to create this cultural awareness and cultural recognition of a viable lifestyle for us, not only for women and men who want to conceive, but for those of us who are aging, those of us who really want to avoid the chronic degenerative diseases that are killing us, this does need to become a lifestyle. Sauna has been shown, and I'm going to refer to the term medical sauna here because that's a little bit different than what a steam sauna that you go to into your gym, but a dry heat medical sauna has been shown to increase the urinary excretion of several fat-loving persistent compounds and metals. And so using that, like the Finnish people have been doing for centuries, is not a bad idea. It's a good idea. Of course, you have to hydrate, you have to replace your electrolytes, but as a methodology for removing toxicants, it can be very helpful. Not for all of them, but for a large proportion of them. So I would add that in there as well.
So for what period of time would you start to notice that your detoxification is taking place, that you're asymptomatic of having been exposed?
Well, that's so variable. If you're talking about someone who's diagnosed with an autoimmune disease.
Somebody who's showing symptoms of an autoimmune disease, who might have a marker indicating that there's an autoimmune disease.
They have antibodies.
Right, but not necessarily a specific diagnosed autoimmune disease. Mm-hmm.
It's so hard to answer that question without going into specifics, but I promised you a 2-minute answer. We're long overdue. Okay. We're very clear that this is not, there's no magic involved. That over a lifetime of accumulation of toxins, you can't get rid of them in 3 to 7 days. But in 6 weeks or 12 weeks, you can make a marked difference in your body burden. Now that's that's working at it on a daily basis. That's, I think, realistic for more difficult autoimmune diseases. We're looking at 6 to 12 months. Especially if we have a body burden of metals. Metals do not come out overnight, nor do those lipophilic fat-loving toxicants like PCBs. But we can get someone to a significantly different state in their health by doing that. you want to hear a quick patient story?
Yeah.
Okay. So I had a teacher who came to me. She was retired, but she had spent her entire life in the school system, who was diabetic and overweight and chronically fatigued. Now, what was interesting about her is she tried to lose weight by being on the Atkins diet, which she loved, because she could have unlimited amounts of butter and steak and fish. She loved some of the higher fatty fishes like swordfish and tuna, but she had not lost any weight. In fact, it had backfired on her and she had gained weight. Now, this patient was a couple, I think probably about the 2004 or 5, somewhere in there, before we really understood a lot about environmental exposures to PCBs. Now we know that PCBs were used in caulking in construction in the 70s. And so many colleges and schools, they're really having to do retrofitting because these PCBs become airborne and they can be breathed in. She mentioned to me that her school, there was a school she'd worked in on the East Coast for quite a while that they had to evacuate, or they had to leave because there was some toxicant exposure. And I said, is it asbestos? She goes, no, it wasn't the tiles, it was something in the caulking. I think right around that time, maybe a couple years later actually, a paper came out looking at PCB levels in the blood of teachers and students in schools where there had been identified PCBs used in the caulk, and they were significantly higher. So this is an actual area of research for many doctors to look at this. But anyway, the bottom line is we did blood levels of PCBs on her. We actually tested her, and she was loaded with PCBs. So the protocol for her was to go off of an Atkins diet and onto a low PCB diet, which would be no butter, no steak, no fatty fish. And she did okay with it, actually. It was a bit of a transition because she was afraid of carbohydrates. She was a little carbohydrate adverse, but she really needed to stop putting these sources of PCBs into her body. We also got her to go into the sauna, which is an excellent way of depurating or getting rid of PCBs. We had a medical sauna in our clinic. We don't have it anymore, but we had a medical sauna. It could fit up to 6 people. It was temperature controlled. We had a nurse who would monitor folks in the sauna to make sure they were doing okay and drinking enough, hydrating, getting enough electrolytes. And so we put her on a protocol of daily sauna, 5 days a week for 6 weeks. And that's kind of the standard. Working her up to an hour in the sauna every day. We also put her on a high fiber, very specific form of fiber, high chlorophyll, which is actually researched as an agent that increases PCBs in the bile, in the stool, diet, so a lot of salad. And she did okay with salad because salad wasn't going to hurt her at all. She, at the time, was diet controlling her diabetes because, as you know, if you have type 2 diabetes and you go off of carbohydrates, you can diet control pretty easily. So she was actually able to keep her hemoglobin A1C and her insulin down on this low PCB, high vegetable fiber, vegetable protein diet. Her diabetes went into remission, basically. And she lost about 50 pounds over the ensuing 6 months. What was fascinating to me and has been reported in the literature is at one point she had a breakout of what's called chlorogenic acne. So these PCBs, like many other of the older pesticides that we house in our bodies that are no longer in commerce, they contain chlorine. And people who worked in factories where they make PCBs, researchers and Ahmed docs know that they get this very specific kind of acne where their bodies are trying to get rid of the PCBs. So she had this terrible outbreak of this chlorogenic acne on her skin, and I said, well, it's temporary. Trust me, it's temporary. And in fact, it was. It healed. She didn't have it again, but those were the PCBs coming out through her skin. She was sweating them out. So anyway, she was very happy, as you can imagine. Because she had worked so hard. She'd been so diligent. She just didn't have the guidance to A, identify the toxicant in her body, and B, the specific route for elimination. She had to stop putting it in and start getting it out. And so she also was on some binders, you know, charcoal and clay. And there's really no good research on that, so I kind of hesitate to, to talk about it. But I think there is some evidence that they will stop the reabsorption of those PCBs in the intestinal tract. So that was her story.
What a story. Well, thank you so much for joining us today, Dr. Patrick. You've given us a wealth of information.
Oh, I hope it's been helpful.
It's been helpful,
Good.
and it's been frightening.
We'll talk.
Okay.
We'll talk.
And best of luck to you.
Oh,
Thank you for all of the work that you're doing.
Sure. I'm happy to be here.